Respected doctors, my name is Dr. Aishwarya and I welcome you all to the Surgical Herald webinar. The topic for today is acute pancreatitis. Sir, for today's webinar. Shivram sir is the head of the Department of Surgery and Allied Special Program Director, Bariatric and Metabolic Surgery at Astra CMI Hospital, Bangalore. National Executive Committee member of Associations of Surgeons of India. Executive Board member of Obesity and Metabolic Surgery Society of India. Sir is a PG teacher accredited by the National Board of Examinations, and Sir has written book chapters and has publications in national and international journals. I request Sir to take over the session now. Thank you.
Thank you. Thank you very much, Zydus. We have a very distinguished speaker today to talk of acute pancreatitis, the step-up management. Dr. Manish Joshi is a renowned senior consultant surgical gastroenterologist, and he is at the Bannerghatta Fortis Hospital at Bangalore. He is a HPB and robotic surgeon. He is known for his academic initiatives. He conducts every year the very well-known GI masterclass series of the national level conferences, and he conducts Rajiv Gandhi University fellowship programs. He is the director for that, and his special area of interest is pancreas. And it's very apt that we are discussing about acute pancreatitis, the step-up approach today. As you all know, acute pancreatitis is a very serious problem. Large population, 270,000 patients occur every year. This about 20% may get necrotizing pancreatitis, and then about 1/3 of them may develop infected pancreatic necrosis, and some of them definitely, about 95% of them require some type of intervention. So earlier, it was all the open pancreatic necrosectomy. Then we had laparoscopic approach, but the morbidity and mortality used to be high. But something happened in 2010, the Panther trial of Dutch group, which changed the entire thing. The randomized control trial showed that the approach of step-up approach gives much better results. So then there are modified methods in this. I'm sure Dr. Manish Joshi will take us through this journey of acute pancreatitis step-up approach. Thank you all. And if there are questions, please send it through the chat box available to you, and we will try to take up as many questions at the end of the talk of Dr. Manish Joshi. Till then, let us not disturb him. Over to you, Dr. Manish. Thank you.
Thank you very much, sir, for the kind introduction, and thank you, Zydus, for this opportunity as well. And pancreas is rightly one of the challenging organs from the PG trainee times and now even in practice. So I'm just going to start off by sharing my screen. Are you able to see my screen?
Yes, sir.
Yes, Manish. Yeah, that's better.
So severe acute pancreatitis is one subset of pancreatitis, which I'm going to highlight as to what exactly, why it is so challenging and why it is so intriguing, and sometimes it is very frustrating as well. Uh, from the early times, it was always mentioned in surgical books that for trainees, eat when you can, sleep when you can, and don't mess with the pancreas. And one of the reasons why this was mentioned is because of this condition called pancreatitis. Acute pancreatitis is a very varied clinical condition, and it has a spectrum of presentation, sequelae, and manifestations, which make it very challenging to manage. So let's get and dwell deep into it into the next 30 minutes or so. What I have tried to curate and customize in this presentation is how to help each practicing surgeon or each practicing physician or a younger surgeon into managing this challenging disease called as acute pancreatitis, especially the subset of severe acute pancreatitis. There are a lot of theoretical and a lot of other discussions that can also be discussed about acute pancreatitis, which I've purposefully eliminated from this 30 minutes so that there will be meaningful discussion on the controversial areas and on areas where practice can be changed or the practice pointers can be utilized in managing such a challenging condition. So without much ado, let me start off with saying that in 2010, as Sir rightly mentioned, because of the Panther trial, the new word was coined in the management of severe acute pancreatitis, which is the step-up approach. So let's quickly look at a video and see what we are talking about in acute pancreatitis. So this is one of the patients, 58 years old, gallstone pancreatitis. We managed with the step-up approach over a period of 2.5 months. And then he developed walled-off pancreatic necrosis, and we had to go in. And this is what you can see in the video, that we are going in through the anterior gastrotomy and the posterior gastrotomy into the lesser sac. And this is what we say, that it's challenging not only to plan, it is challenging to time the surgery, and it is challenging because in spite of all the CT imagings and other things, we still are caught by surprises in pancreatitis. And it's a difficult spectrum to devote to unless you're really, really interested in this particular aspect of GI surgery. You can see a bit of necrosis there and a bit of fluid under pressure, which is slowly being teased off and being removed. So this is what we are going to talk about. This is one of the easier operations, I would say, because we had managed the patient according to the step-up approach. So this is what is happens in practice, but let's go and start from the basics. So this is the Panther trial, which Dr. Shivaram had mentioned, which brought about a landmark change in the management of acute pancreatitis. This was a multi-center randomized controlled trial by the Dutch pancreatitis group, which brought out such an impactful paper that this is available free of cost and has free access. So each one of you can easily access it on the internet. It is available. You don't have to pay for it. It is free access because of the impact it has created. You can see it online and you can get it on any GM as well. So in 2010, the Dutch pancreatitis group did a randomized control saying, let's avoid surgery. Let's treat acute pancreatitis like a medical condition and see if we can get better at it. And instead of a step-down approach, let us get into a step-up approach. And let us understand what exactly it means. So let's start off with the simple and basic definition based on the Atlanta criteria, what exactly is acute pancreatitis and what are the various severity of pancreatitis that we are talking about. Because ultimately we are going to focus on severe acute pancreatitis. We should understand what we mean by it. So acute pancreatitis is an inflammation of the pancreas with a raised amylase or lipase along with abdominal pain. So that is to diagnose pancreatitis. Now, once we diagnose pancreatitis, most of us have to categorize it into these three categories: a mild acute pancreatitis, a moderate acute pancreatitis, and a severe acute pancreatitis. So the mild acute pancreatitis is a simple pancreatitis where there is no organ failure and there is no local or systemic complications. So it's a simple thing to understand: pancreatitis without organ failure, pancreatitis without local or systemic complications is mild acute pancreatitis. So let's move on to the other spectrum, severe acute pancreatitis. So if mild acute pancreatitis did not have organ failure, did not have local or systemic complications, severe acute pancreatitis has local or systemic complications or has organ failure. So it's very easy to distinguish between mild and severe. So what is this middle category of moderately severe acute pancreatitis? So in moderately severe acute pancreatitis, patients may have local or systemic complications or organ failure which are transient. So which may appear like acute renal failure, but it improves within 48 hours. So if it is transient, it is categorized into moderate severe acute pancreatitis. If it continues and persists, it is called as severe acute pancreatitis. Once we understand this distinction, it becomes easier to categorize all our patients that we see in our clinical practice. Most important is to understand the pathophysiology. So let us look at this chart and understand what is acute pancreatitis and what subset of severe acute pancreatitis we are going to deal with. So if you look at the bigger circle, almost 80 to 85% of acute pancreatitis fall into the mild variety, thankfully, which has no organ failure and which has no local or systemic complications. It is only this particular 15 to 20% subset which goes into organ failure, and which is what we are going to talk about in the next 25 or 30 minutes as severe acute pancreatitis. So if you look at the mild acute pancreatitis, the mortality is less than 1%, and most of them do well. So we can compare it to the COVID pandemic as well. So mild variety do not require major intervention, is not very challenging to manage, and the mortality is less than 1%. If you look at the subset of severe acute pancreatitis, the 15 to 20% who go into organ failure or go into infected necrosis, you look at this subset, the mortality is as high as 25 to 70%. So in this COVID pandemic, you can relate it to the symptomatic or the ones who require ICU. So this is why this subset is the one which is more challenging, and we are going to focus upon this subset. And we are not going to be focusing upon the mild acute variety at all. These two slides, the one which I am showing and the next one to follow, will make an understanding of severe acute pancreatitis complete and as to why the step-up approach works. This is the severe acute pancreatitis, and if you look at this pathophysiology, this is week 1. In the week 1 of acute pancreatitis, in which there is organ failure, there is severe SIRS reaction. And because of this severe SIRS or inflammatory reaction, the inflammatory markers increase in the first week. In the second week, the counter anti-inflammatory markers start produced by the body start attacking the inflammatory markers and start diluting them. So this is the pathophysiology in the first week and the second week. And it is in the second week that the bacterial translocation and the gut microflora cause the infection. So in the first week, it is all inflammatory response. And in the step-up approach, the first week is given much importance by saying, let us not meddle in this inflammatory cascade. Let us just dilute it by giving more fluids. And let us intervene when actually after the second week or third week that the anti-inflammatory response has occurred and the infection and sepsis starts. This is the time to actually intervene and do something. So this pathophysiology makes it interesting and makes the understanding of step-up approach much more clearer. So going quickly into the comparison, before 2010, before the Dutch Panther trial, open surgery was almost always performed in the first week itself of acute pancreatitis with organ failure. And there was a morbidity which was high and a mortality close to 30 to 40%. And as a trainee, I would see multiple operations done in the same patient and maybe a relook laparotomy after 48 hours, crisscross incisions or gridiron incisions with a lot of packing because of bleeding, because we went in early. And the understanding changed because of the step-up approach. And now we are moving on to initial part is ICU and antibiotic management and fluid resuscitation, followed by percutaneous drains and minimal invasive surgery. So this is the step-up approach where we go with ICU management, fluid resuscitation, if required antibiotics. If still things don't work, then go for percutaneous drains. And the last option is minimal invasive surgery. And if that doesn't work, then open surgery. This has brought about the sea of change in the management of severe acute pancreatitis. So this is going to be the practice mantra that initially you have to delay interventions by medical management, by fluid resuscitation, and by antibiotics. And the second step that you take is not surgery, you drain. And if drain also doesn't help and things persist, then you think of debridement. So delay, drain, debride. And this is going to keep repeating because this is one thing which is very important in the management of severe acute pancreatitis. And why do we do that? A picture is worth 1,000 words, and this is why we do that. Initially, when we used to go in early in the first week, the pancreas was not devitalized and it was not ripe. And if we go in early, we used to take healthy pancreas out along with the necrotic pancreas and cause a lot of bleeding, cause a lot of morbidity, and it didn't work. If we wait, if we delay, if we drain, and then when things are ripe, if we go in, we can easily peel out or debride the devitalized pancreatic tissue. And this is the reason why we need to wait, why we need to delay the intervention for up to 4 weeks. So pancreatitis is like this. This is a earlier video wherein if we go in early, all the anatomical planes are all stuck together. You can hardly recognize anything, and it will be difficult to go in and find out the right planes. And because of this, the morbidity used to be high and mortality also used to be high. This is a patient we had managed for up to 3 weeks and persistent organ failure and persistent fever. So we had to intervene in spite of trying PCDs. Because of the location, it was not feasible and the percutaneous drain had blocked. And this is what I meant when we say if we delay it, we can get the devitalized tissue out clearly. And this happens only if we delay the interventions. Preferably the thumb rule is 4 weeks. And this is how it easily comes off once the pancreas is completely devitalized. You can easily tease it off the normal pancreas. So most of these videos or steps and techniques remain the same, except that it's a laparoscopic approach, and this is a transmesocolic approach going into the lesser sac. We'll discuss those technical details as well in a bit. So let us look at, for the younger surgeons and for the PGs, one thing is very important. Since we want to delay the intervention for up to 4 weeks as a thumb rule, we need to also mention that the onset of pancreatitis pain has to be the first day recorded in the case sheet. It is not the day of admission of the patient, but it is the onset of abdominal pain, which is recorded as day 1, so that we can say and categorize whether this patient is first week, second week, third week, or is all ready for any kind of intervention if required. So even if you are not able to manage the patient, if you're referring the patient, it would be most ideal if you can record saying patient is day 4 of pancreatitis from the onset of abdominal pain and not the time of admission to the hospital. If you're a tertiary care center and managing such patients, please record the exact date of onset of abdominal pain, and that will be the day 1. So there are pancreatitis group guidelines as to what to do in the initial phase. So we are going to the step-up approach, and we are trying to do what is practically applicable. And we are not going to discuss all the theoretical aspects, but we are looking as to what can be done in the initial part. So these are taken from the guidelines by the pancreas group. Initially, we mentioned that the first week is all inflammatory cascade. So if we have to dilute the inflammatory cascade, all we need to do is a good fluid resuscitation. And in this fluid resuscitation, the initial 48 hours is critical, in which we give a goal-directed fluid therapy. And it is the key to convert a severe acute pancreatitis into a moderately severe acute pancreatitis by adequate fluid resuscitation and trying to hydrate the patient well, dilute the inflammatory cascade, and bring down the organ failure from persistence. The second question that we need to ask is, does this patient require ICU admission or not? Initially, you may admit the patient to the ward, or initially, if the patient is not well, you may admit the patient into the ICU. But based on the severity scoring, or based on whether you categorize the patient into mild or severe acute pancreatitis, all mild acute pancreatitis can be managed in the ward. All severe acute pancreatitis, you should consider ICU admission because they will require close monitoring. So these are the two initial things that you need to focus on in practice. Let's look at what fluid and how much to give. So there's clear-cut guidelines saying Ringer's lactate is the fluid of choice in the first 48 hours, and it brings down the inflammatory cascade as well. And the idea was to give more fluids initially, almost 125 ml per hour or 150 ml per hour. But because it depends on the body weight, we might not be correct in just putting 125 ml per hour or 150 ml of Ringer lactate per hour. It is more appropriate to do a goal-directed fluid therapy of 5 to 10 ml per kg per hour. So there are two ways. One is you can use the body weight and direct the fluid therapy. The second is also ensure that there is adequate urine output. And the initial 48 hours, the more fluids you give in, the more dilution of the inflammatory cascade, and you may likely convert a severe acute pancreatitis into a moderately or a transient organ failure kind of pancreatitis. So this is very key. Hydrate, fluid resuscitation is the key in the initial 48 hours. So the other question which comes is, when do we start feeding, and do we use the enteral route or do we use TPN or just put the patient on fluids. So there has been enough evidence to suggest that if the patient does not have vomiting, if the patient is clearly diagnosed to have acute pancreatitis and you're not having any dilemma about it being a DU perforation, if there is no peritonitis, if you're not suspecting a duodenal perforation, and if your amylase is raised 3 times or lipase is raised 3 times, you could actually start the patient early feeding, and you can use the enteral route. Enteral route is the best route unless the patient has vomiting. Enteral route is the best route until you are actually, unless you're not sure whether it is acute pancreatitis or you have something else in mind. So initially, if there is a diagnostic dilemma, you are okay to keep the patient NPO, give IV fluids, get the values done, and once you have diagnosed acute pancreatitis, to start early feeding and use the enteral route. And do we have evidence for that? So we have a meta-analysis, again from the Dutch group, which are very focused on acute pancreatitis. And they brought out the timing of enteral nutrition. And in the conclusion, they said starting enteral nutrition or using the gut within 24 hours is much better than after 24 hours. And if you start the enteral nutrition within 24 hours, even you can start oral liquids. If you don't want to start oral diet, you can reduce the complications. So we have answered a few more questions. Let's look at what next if we are still not, if the severe acute pancreatitis persists in this step-up approach, what more can we do? So we had mentioned that the initial thing is ICU and fluid resuscitation. The second thing would be antibiotics, but not all patients require antibiotics. We have seen the pathophysiology that the first week is an inflammatory cascade. So the white cell count is bound to rise. All acute pancreatitis patients have a high total leukocyte count. It doesn't mean there is infection, it just means it is inflammation. And we do not need to start antibiotics straight away. And another important point is we do not need routine FNAC to detect any bacterial infection. And this was earlier practiced, but now we have got better with our CT imaging, and we do not require routine FNAC to diagnose infected pancreatic necrosis. So let's look at the controversial point of doing a CT scan. So CT scan, when do we do it? Like we mentioned, the pathophysiology of pancreatitis is the first week is inflammatory response. If we do it too early, all we see is the inflammatory response. We are actually not going to pick up anything worth managing in the first week. In the second week, we get a lot of infected necrosis and bacterial translocation. So if we can avoid CT scan in the initial phase, we will be more better by, so I'll give you an example. If you do a CT scan in the initial phase, it will look like interstitial edematous pancreatitis, but we are not doing CT scan to diagnose pancreatitis. More or less, we need to manage it. So if we do it a bit later, a week, or if the symptoms persist, then we do it. You can see these kind of retroperitoneal gas shadows, and you will pick up infected pancreatic necrosis. And that is why, because of this advances in the CT and the thin film cuts, we are able to diagnose retroperitoneal gas shadows and infected pancreatic necrosis with imaging itself. And that's why we do not require routine FNAC. There's one caveat here. In the initial admission, if you're suspecting DU perforation or acute mesenteric ischemia or any other reasons for acute abdomen, you can go ahead with a CT scan if you are in a diagnostic dilemma to rule out a perforation or any other cause. But if you have diagnosed acute pancreatitis, in the first 48 to 72 hours, there is no real role of doing a CT imaging because it doesn't help with the management. And you'll be anyway doing a CT scan later based on the clinical symptoms and based on the manifestation. So again, back to this particular step-up approach, we have talked about ICU, fluid resuscitation, and antibiotics. If we see retroperitoneal gas shadows like in the previous CT scan, and if the patient is having fever and clinical signs of worsening, we need to start antibiotics at that point of time. Imipenem cilastin is the antibiotic of choice. And if you start it, you need to continue it for 10 to 14 days. So we have talked about ICU admission, we have talked about fluid resuscitation, we have talked about CT scan being delayed till 1 week at least. And if there is imaging showing infected pancreatic necrosis correlating with the clinical picture, then we start imipenem cilastin. So this is the first step in the step-up approach, that is the medical management. Let's look at when to intervene and how to intervene. So again, the practice mantra: delay, drain, debride. And this is why we do it. So drain. So the next step in management, we have tried to delay the intervention by ICU admission, fluid resuscitation, antibiotics, and still the person or the patient is not improving, and patient is coming back with vomiting, pain abdomen, or fever. That is the time that the first intervention that we need to choose is to drain. And by drain, we mean a percutaneous drain. And it can be done anytime if you feel that you tried delaying with medical management adequately for a week or 2 weeks at least. And if the fever persists, we are left with no option but to intervene with a percutaneous drain. And do we have evidence that it works? So again, the Dutch group have brought about a systematic review of percutaneous catheter drainage as the primary treatment for necrotizing pancreatitis. And with percutaneous drain alone, in the paper they had mentioned almost 70 or 72% of patients can be treated with percutaneous drainage itself without the need for surgical necrosectomy. So that's a high subset of patients where we can manage with just percutaneous drains. Initially, we were confined to single percutaneous drains, but now recently another paper has come by this Dutch group saying that if you're not happy with one percutaneous drain, if symptoms are still there, instead of going for surgery, you can put in multiple percutaneous drains, and that would help manage the severe acute pancreatitis much better, and you can avoid surgery. So you've delayed the intervention, and then you've tried draining as the first intervention. If the first percutaneous drain doesn't work, you can see and repeat a percutaneous drain, put in multiple PCDs if you have a good interventional radiologist. And that may avoid the surgery in this step-up approach. So finally, we come to the last part as surgeons, when to debride. And this is a choice which has changed dramatically because of the step-up approach. Initially, open surgery used to be the first option given to a patient with infected pancreatic necrosis. And now we realize that because of the inflammatory cascade, going in early will be adding salt to injury. So we need to wait and we need to delay, we need to drain and then only debride. So there is a small subset of patients, in spite of medical management, in spite of fluid resuscitation, in spite of antibiotics, in spite of percutaneous drains, who develop symptoms or who have persistent organ failure or who have persistent clinical symptoms of fever, vomiting, abdominal distension. And these are the subset of patients that we need to consider surgical debridement. And the choices are up to us because of the increased advances in the technology. These are the 4 choices available to us to debride the devitalized pancreatic tissue or the infected pancreatic necrosis. So just dwell on this particular diagram. It is so there are 4 approaches. Option A is you look at the pancreas as a retroperitoneal organ and we can approach the retroperitoneum through percutaneous drains using the retroperitoneal space itself, and then slowly dilate the drains and get into this retroperitoneal space and do a necrosectomy, which is called as video-assisted retroperitoneal debridement or WARD, which was the favorite of the Dutch. All the Dutch centers used to use WARD as the first option. So look at option B. Option B is endoscopic transgastric necrosectomy. So if you have a good medical gastroenterologist and a good backup support team, then it is worthwhile considering endoscopic transgastric necrosectomy. Already the gastroenterologist would be happy doing endoscopic cystogastrostomy. And this is one step forward where they do an endoscopic transgastric necrosectomy. So get into the stomach. If based on the CT scan, if there is a bulge into the stomach already seen, enter into the necrotic area through the posterior wall and put in a stent. A Nagi stent is commonly used, which is Indian made by Dr. Nageshwar Reddy. And this is the commonly used stent for endoscopic transgastric necrosectomy. But you need to have good expertise for that. The option is laparoscopic option, and laparoscopic or open option would remain the same, only the approach is different. And there are two options that we use. One is we can use the approaching the lesser sac or the transmesocolic route. That is, we go between the stomach and the colon into the lesser sac and approach the infected pancreatic necrosis through the transmesocolic route. Or we go through the, just like we do a cystogastrostomy, we approach the infected pancreatic necrosis through the cystogastrostomy. So these are the approaches that we can use for necrosectomy. And if you have the expertise, interventional radiologist, then you can opt for WARD. If you have a good medical gastroenterologist, you can opt for endoscopic necrosectomy. Or if you are a good laparoscopic or a robotic surgeon, then you can go ahead with necrosectomy through the minimal invasive approach, either transmesocolic, or you can go through the transgastric approach like a cystogastrostomy, which are the commonly used ones. All these approaches are based on the CT finding, which is the predominant area of the infected necrosis. Is it in the head, the body, or the tail? Usually, if it is a body, then you can use a laparoscopic transmesocolic approach or the lesser sac approach or the endoscopic approach. If it is near the tail, you can use the WARD approach and do a retroperitoneoscopy. This is very important for all the surgeons to understand and all the people managing severe acute pancreatitis. Based on the CT scan imaging, you need to have a multidisciplinary team approach and identify how best to approach this and do the necrosectomy. So let's look at one of the cases that we had managed, an elderly lady who had acute pancreatitis. We managed for almost 6 weeks, and again she came with a recurrent bout of pancreatitis and had persistent fever and a walled-off pancreatic necrosis. So this is the diagnostic laparoscopy. You can see that there's some momental saponification because of the recurrent pancreatitis. We were actually wanting to delay this a bit more further, but the patient kept on having severe abdominal pain, vomiting, and the CT scan was showing that there was a walled-off pancreatic necrosis just abutting the body of the stomach. So it was suitable for an endoscopic approach as well. However, because of collaterals, the endoscopic approach was not preferred. Our gastroenterologist did EUS, endoscopic ultrasound, and identified blood vessels close to it and asked us to intervene. So we have done an anterior cystogastrostomy. We have identified with the posterior cavity with a needle, and we are going in and approaching the cavity or the lesser sac, which contains the infected pancreatic necrosis. However, there's one more concept called as fluid under pressure. You just saw this fluid which is coming out is contained in the lesser sac. So this fluid under pressure can also cause the severe inflammatory response. And because of this fluid, if you can look back, the drainage works because the drainage will take care of all this fluid component. And if the drainage in 70% of it works, it means that the taking care of the fluid itself is sufficient in 70% of the cases. So we are using a vascular stapler to try and open up the lesser sac through the posterior wall of the stomach. This we do it for two reasons. One is to get adequate hemostasis and to get a good opening. And this is a easier method than trying to do with any vascular shears or harmonic shears. So once we open up, you see the fluid and the devitalized tissue, which is the infected pancreatic necrosis, which needs to be slowly teased out and collected into an endo bag. So this becomes a laborious process, and why our endoscopic colleagues may want to ask us to do the necrosectomy is because of this. We have good instruments in the laparoscopic or robotic arms, which we can use to hold and take out larger chunks of tissue as compared to endoscopic means. They just have the biopsy forceps, which they have to keep going in again and again. And the one reason why endoscopic cystogastroscopy is not preferred is because you have to do multiple sessions to remove all the necrosis. Whereas in the laparoscopic approach, like you can see here, we can almost always take out 70 to 80% of the necrotic area easily. So this is why we are delaying the intervention. You can see that the devitalized pancreas is easily demarcated from the healthy red colored portions. And this is one of the reasons why the endoscopic colleagues do not prefer necrosectomy, because the bleeding is difficult to control if it happens in an endoscopic approach. And once the necrosectomy is done, sometimes we put in a Ryle's tube, or if we have done a lesser sac approach, we would put in 2 drains to irrigate it in the postoperative period. And then we close the anterior cystogastrostomy. And this would be the end of the procedure by a minimal invasive approach. And the stomach is a vascular organ. Stomach is the approach through the cystogastrostomy works well, whether it's a pseudocyst or whether it's infected pancreatic necrosis, if the necrosis predominantly is in the body. If it is in the tail, then you would have to use the transmesocolic approach, or you would have to use the lesser sac approach. So these are the practice pointers, and I'm coming to almost the end of the presentation, and I'm trying to wrap up by saying there are some things which are very clear in the management of severe acute pancreatitis. One is that the diagnosis, if it is clear with a raised amylase or lipase, makes it easy to manage. And if you can categorize it into mild or severe acute pancreatitis in the first 72 hours, it becomes more easier to anticipate the challenges that are going to ensue and to counsel the patient family as well, which is very important, because sometimes the patient families, we need to keep telling them that this is a prolonged phase wherein we expect and anticipate more and more issues to happen, and we have to deal with it accordingly. So we have looked at the step-up approach, and because of the step-up approach, the management has changed, the mortality rates have reduced, and the morbidity has reduced in managing severe acute pancreatitis. There are a few things which are not clear, and which may be one of the questions that can come to your mind. Is there anything medically that can help reduce acute pancreatitis inflammation? A lot of drugs have been tried. The latest one is ulinastatin. Ulinastatin is known to reduce the inflammatory response rate, also known to decrease the intra-abdominal pressure and shorten abdominal pain scores with early recovery. And it is a promising drug in the initial 1 week of acute pancreatitis. However, most of the other drugs have not been found of any value. The second thing which is not clear is the role of scoring systems, because each scoring system or each institute have a different scoring system. And whether it is an institute, they would prefer a Apache 2 scoring system, or if it is a private hospital, they might prefer a CT scan based Balthazar scoring system. Or if it is the intensivist, they would look at BISAP or a simple bedside scoring. And most of it is helpful in the initial 2 or 3 days where we are trying to categorize the patient into mild or severe variety and whether to admit the patient in the ICU or not. But more or less, CT scan, if it is done in the second week, would help us get not only the management point of view, but also the severity scoring also additionally. So it is my preference of choice to do a CT scan severity scoring index, but the other scoring systems as well, which can be looked at. I think we have covered most of the important practice pointers, and I would just like to leave you with these 3 slides. And this is the step-up approach. We have also mentioned the initial ICU, fluid resuscitation, antibiotics as the first step, percutaneous drains as the second step, and minimal invasive surgery if preferred to open surgery. And this is the practice mantra for acute pancreatitis, the step-up approach: delay, 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 drain if required, and debride only as a last resort. And this is why we do it. Thank you very much for your kind attention, and thank you, Zydus, again for this opportunity.
Thank you.
Any questions?
I think you have made it a difficult topic very simple and clear. The message is very well brought out in the picture of banana ripening and also the management of delay, drain, and debride. So there are some questions which have come up. Before that, see, this step-up approach is there for last 10 years or so now. What's your experience, the clinicians adhering to this protocol and managing severe acute pancreatitis by this approach? Why I'm asking is there are literature which say that whenever there is a RCT and a research evidence comes that this is the best, we have to change, there is about 17 years of delay where it comes to the clinical practice. For it to become a practice guidelines, it becomes many more years. So what's your experience in this, Dr. Manish?
Sir, a very relevant question, and I was very thankful that I have seen the phase where open surgery was being done as a surgical trainee. I've seen the morbidity and the mortality of pancreatitis, and I actually used to hate this kind of conditions. And then in the further training in GI surgery, I realized that when the step-up approach had actually been started practicing, there was a sea of difference. More and more patients were getting better, and more patients were not requiring all those morbid surgeries that we used to do earlier. It has made an impact on me because I have seen the contrast. Maybe the next generation and the newer people, if they start taking up step-up approach, they may not be able to compare it with the grief and the difficulty that was faced in the open surgery era. But I think this has become a game changer, if not in all toto, based on your hospital's expertise and availability of local resources, you could choose to modify and use few of the things or many of the things of the step-up approach in your practice. And even if you use few of the things, it will work in your favor and in the patient's favor. In the last 3.5 years, we have made an audit of severe acute pancreatitis of 281 cases that we have managed, and all using the step-up approach. And the number of patients who require necrosectomy, we have done both endoscopic as well as laparoscopic necrosectomy, have considerably reduced. Our main intervention has become percutaneous drains, and antibiotics. These are the two main things that we use to delay as well as to reduce the severity of pancreatitis.
Right.
Nephrostomy is a challenging surgery, and though the numbers have reduced, there is still, I feel there is a rising incidence of acute pancreatitis per se
Right.
than seeing from earlier times.
Thank you, Dr. Joshi. Um,
Yes.
Question from Dr. Srishail Metgood from Belgavi. What is the incidence of managing massive hemorrhage during necrosectomy? And what are the strategies for managing massive bleeding during necrosectomy?
That's a very interesting question, and hemorrhage is one of the main fears of both the surgeon as well as the endoscopist who's doing.
Dr. Manish, can you stop sharing so that we can have a broader view in the, yeah, go ahead.
So hemorrhage is the main fear in the endoscopist as well as the surgeon's mind whenever he or she is doing a necrosectomy. Uh, in the laparoscopic approach, we always keep our bipolars as well as the harmonic shears, and if possible, the ligature also available. And we use liga clips wherever possible. But the idea, if we want to prevent anything, is to have a close discussion with the radiologist in the CT scan room before any surgery, before any endoscopic approach, and to see if there is any collaterals, any main vessels, especially the splenic artery, as to where it lies and whether we are going to be in close contact or how far it is from the area of where we are going to intervene. If we can plan it well, maybe we can avoid it. If we can't avoid it, then we have sometimes have to use all the means available. Sometimes we have also packed it, the lesser sac for about 15-20 minutes and then come back in and had a relook and seen if it is stopped. There have been occasions where we have almost converted it into open surgery, thinking that the bleeding won't stop, but it does stop. If you can pack it, it is a contained area. And if you can put a pressure and have the patients, meanwhile, get things arranged to have a possible conversion. Sometimes it works, sometimes we have to open up. Ultimately, it's the local resources that is available and how you anticipate and how good your OT team is in anticipating and arranging things make a lot of difference.
Right.
If one particular hospital, one particular OT setup, people are used to you and these things, these challenging cases, it works really well.
Thank you, Dr. Joshi. I think you mentioned very well. Best is not to have it, prevent it, and plan it well. If it all happens, pack it either laparoscopically, and sometimes we may have to open and tackle the bleeding. Still, it's not possible. We may have to pack for a day, 48 hours, and then go back and see. And very rarely we may use the radial, take the help of embolization. Those are the things. See, other question from Dr. Rahul Chaudhary from Delhi. Not all severe acute pancreatitis patients require antibiotics. How to know which patient needs antibiotics?
Fantastic question.
Choice of antibiotics, you have already mentioned, you can cover it.
Yeah, fantastic question. Most acute pancreatitis patients, if you are the person seeing the patient for the first time, then you actually have the choice in your hand. If you can diagnose acute pancreatitis and avoid starting antibiotics in the initial 4 or 5 days, that is the best way. Unless the patient has extra pancreatic infection, we don't need antibiotics in the first 1 week. How to add antibiotics is if the patient develops fever in the second week or so, when we are expecting that the infected pancreatic necrosis may start happening, that is the time that we think we should start antibiotics. If at all the patient is having fever and we know that there is no extra pancreatic infection, no thrombophlebitis and no urinary tract infection, no chest infection, then we are okay to start imipenem cilastin. However, there are patients who have comorbidities, who have chest infections or urinary infections. And then in those cases, it is okay to start on appropriate antibiotics in the initial part as well. To answer your question, acute pancreatitis, if it is diagnosed early, do not start antibiotics, wait for the fever phase to happen and then start antibiotics, or based on the CT scan, retroperitoneal gas shadows, then the patient is deteriorating, then start antibiotics. Otherwise, for extra pancreatic infection, you can use it. If you are not the first person to see the patient, if the patient is being referred to you, sometimes the patient comes with already preloaded antibiotics. You don't have a choice, you just continue it and stop it appropriately, and then again go back to the step-up approach and wait for fever and clinical symptoms to help you decide.
Thank you, Dr. Manish. Yeah, I think first week fever, you should not worry too much about it. It's more of chemical pancreatitis. It may not be infected. Even second week also, you should not worry. But third week, fourth week, and also clinically, patient is deteriorating. You see that in the CT, there is evidence of infected necrosis in the form of gas. That was the time when you have to really think of antibiotic. I think you have answered it very well. Dr. Praveen Joshi from Pune, which is more preferred practically, ward or endoscopic necrosectomy?
So,
Yeah, again, it depends on where exactly the collection is more, I think. If it is retroperitoneal collection more, you can go for ward. Endoscopic necrosectomy is you have to see whether there is a bulging towards the stomach. An endoscopic ultrasound, you do see that it is more suitable. So that's what is my impression. So you can tell Dr. Manish.
yeah, more or less, it also, apart from the comments you made, sir, appropriately, based on the CT scan and the position of the necrosis, third most important component is the local expertise available. If you have a good medical gastroenterologist in your team, you are more inclined towards doing endoscopic. If you have a very good interventional radiology team with you, you are actually going to choose ward as well. So based on your local expertise, resources available, you can optimize it to help the patient in the best approach available. All are equally good. Endoscopic seems to be getting ahead of the race because the approach and the recovery is faster. However, hemorrhage and bleeding is the limitation in endoscopic approach. So if you ask, my order of preference is, if endoscopic is possible, yes. Second, if laparoscopic is possible, it is the second best option. Third would be ward. With ward, you will have to do multiple visits, and with ward, you'll have to leave a tube on the side of the patient, and most patients, whenever we have tried ward, are unable to sleep well and complain because of the tube. If it is an institute, you can still opt for ward. In private practice, more or less endoscopy or laparoscopy would be the first option.
Right. Thank you, Dr. Praveen. Um, Rohit Roy from Calcutta. In patients with severe acute pancreatitis, what's your choice of antibiotics kept in mind? There is change of microorganisms from gram negative to gram positive. I think you already said about imipenem.
We would always start with imipenem cilasten, and based on there are 2 or 3 things. What happens is, this is the initial practice pointer to start off with imipenem cilasten. There are patients whom we are managing beyond 2 months, 3 months, and they are not improving. And if you have super added fungal infection, you can appropriately add to that. Sometimes, especially in our practice, we see that our antibiogram or the flora that is caught in our particular hospital practice, our microbiologist brings out an antibiogram every 2 months. And based on that, we know what are the common nosocomial or hospital-acquired infections which are common in our setup. And based on that, we tweak it and add another broader spectrum antibiotic to it. So start off with imipenem cilasten, add antifungals, and look at your antibiogram or the culture sensitivity report and add appropriate antibiotics to it. more or less, this would be not a single person's decision. It would be involving the infectious disease as well as the ICU team and the microbiologist putting in all the inputs, and then we take a combined decision.
Right, right. Dr. Kunal Shaw from Ahmedabad is asking abdominal paracentesis drainage, APD, versus percutaneous drainage alone. Is there any comparison and whichever better in terms of mortality, infection, and all? So, you want to comment on the abdominal paracentesis drainage?
We haven't come across abdominal paracentesis as a first option unless there is pancreatic ascites. So that is a different segment of presentation of acute pancreatitis, where there is a disconnected duct and then the patient presents with pancreatic ascites. So in patients who have pancreatic ascites or pancreatic pleural effusion, pancreatic stenting is one of the best options. In patients who have acute pancreatitis with infected necrosis, there is a component of solid necrosis as well as there is fluid. The fluid component is very well taken care of by percutaneous pigtail drainage. And the interventional radiologist, if they are happy to access it, and if there is a window on the CT scan, that would help alleviate the symptoms if you can just drain out the fluid, which is under pressure in the retroperitoneum in the lesser sac.
Right. Dr. Shivaraj from Mangalore is asking, is there any role of steroids in early stage pancreatitis? Definitely no. Any role you have in shock or anything?
Steroids we have hardly used in managing acute pancreatitis. Unless there is some other reason to use steroids like laryngeal edema or the difficult intubation, we have not used steroids in the initial part at all. Okay. And it doesn't have any role in as an anti-inflammatory response in the initial phase of acute pancreatitis.
Rajesh Kothari from Indore is asking, is this approach medico-legally safe in India?
Very valid question. I would like to put it the other way. If you use the step down approach and do surgery first, the patients are going to have high morbidity and mortality and more likely may go in for medico-legal litigation. If you use a step-up approach and use this particular formula or this particular systematic approach, less likely patients will have morbidity and mortality and less likely to undergo a medico-legal litigation. And because it is very well practiced in most centers, all the experts it is a valid practice and it has been there for more than a decade. And there are improvements and Indian papers also showing that the step-up approach in an Indianized version is also much better.
Right. Dr. Nishant from Bangalore, how to manage a pancreatic fistula post-necrosectomy and how long to keep the drain before doing any active intervention?
Yeah, so there is one point in the transmesocolic or the through the lesser sac approach in a laparoscopic approach to pancreatic necrosectomy is not to make the window too big and allow the drains to go in and make just a small windows to allow for necrosectomy as well as for irrigation to occur. If you make a large window and the pancreatic fistula occurs, then will keep draining the pancreatic fistula. And then usually we'll have to keep the drain for a longer period of time. If it still persists, sometimes we might have to do a pancreatic stenting in a later date to see if it helps reduce the pancreatic fistula. But more or less, if you do the initial approach well and make a small window, do the necrosectomy and put in small drains, irrigate it well, usually in a couple of weeks or maximum 3 weeks, we are happy to take out the drain. And usually the cyst cavity also collapses. For the pancreatic fistula, you can manage it on its own merits with octreotide or with, wouldn't like to continue with the drainage part of it for too long.
Right. Dr. Ashok from Thrissur, after percutaneous drainage, when and how do you decide whether surgery is required, necrosectomy, what's the indication?
So very valid point. And if the symptoms, mainly it is the clinical condition, there will be pressure symptoms like vomiting, gastric outlet obstruction, or there could be infected related symptoms like fever and systemic sepsis. So these dictate as to how we are going to manage after percutaneous drain. So if you have put a percutaneous drain and all the symptoms have come down, then the percutaneous drain has worked. But if a bit later, a few days later, if the symptoms start reappearing again, either the percutaneous drain is blocked or it is reaccumulating in a different location. So that is when we choose to put in another percutaneous drain if it is feasible based on a CT scan imaging. If the another percutaneous drain is not feasible, then that is the time we think the patient will require surgery if we are treating infected pancreatic necrosis. There is another subset of patients who developed walled-off pancreatic necrosis. We have put in the pigtail, we have done the symptoms have come down, we have removed the pigtail, patient has been discharged, and they come back with gastric outlet obstruction or pressure symptoms like vomiting, inability to eat. And then we have to do a repeat imaging, identify the walled-off pancreatic necrosis, and then go in and do the necrosectomy for that particular subset of patients.
Thank you, Dr. Manish Joshi. I think there are a lot of questions which are coming, and we are
Sir.
the time given by Zydus. You have dealt in detail in a very crisp and simple manner about the step-up approach of the severe acute pancreatitis, which is the way to manage severe acute pancreatitis with evidence-based surgical practice nowadays. I'm sure a lot of people will take home this message. And thank you very much for a wonderful talk. Thank you, Dr. Manish. Over to Dr. Aishwarya.
Thank you. Thank you, everyone.
Aishwarya, we can't hear you. Okay. I think there is some communication problem. Thank you, everybody, for
everyone.
your patience and also listening to the thank you, Zydus. Thank you very much. Thank you. Thank you, Manish.
Thank you so much, sir.
Thank you. Thank you so much.
Thank you so much, sir.
And thank you all the participants, and thank you Shivaram sir for an excellent opportunity and discussion. Thank you very much, sir.